Here we discuss pneumothorax as part of respiratory pathophysiology. The literal meaning of this name, pneumothorax, is air in the thoracic cavity. All right? For whatever reason, if you have air occupying the space within the thoracic cavity, the consequence of that is kind of simple. That is, when the lungs fill with air, they expand and fill the thoracic space. But when there is air outside of the lungs, it restricts the expansion of the lung. That means it restricts the filling of the lung with air. That means there is less gas exchange because of the arrival of less air into this lung. All right? So, decreased air, the amount of air available for gas exchange. All right, so less oxygen available to supply the body structures. Pretty serious deal, isn't it? Now, there are different types of pneumothorax. Primary pneumothorax or spontaneous pneumothorax happens suddenly, especially in healthy young individuals, mainly young men and tall, thin young men about 20 to 40 years of age suffer from this condition. All right, so there are many links associated with this condition. Those are smoking, like in most of the respiratory disorders, family history. Marfan syndrome is a connective tissue disorder, a genetic disease, and homocystinuria is the buildup of homocysteine in the blood, and that gets eliminated in the form of urine. So you may see high amount of homocysteine in the blood as well as in urine. Okay, it's a metabolic disease that's associated with many structures, including connective tissue. So here we're talking about it as a connective tissue disorder that has something to do with the construction of the pleura, and both Marfan syndrome and homocystinuria may be associated with structural defects in the pleura that leads to pneumothorax. Okay, now let's talk about other causes. You have heard about bleb before. Bleb is like an air space, a cavity of air, okay, within the pleura. So this pleural bleb bursts, okay, and that's the one that creates a hole in the pleura. All right, so this hole would let you lose this negative pressure that's created within the pleura. Intrapleural pressure is negative, correct? Now the pressure would be the same as that of atmospheric pressure. So without this negative pressure, you cannot really expand the lungs. You cannot really fill that with air. So that is how you would make the lungs collapse. Collapsing of the lungs is the outcome of this. All right? Good. With this, let's move on to talk about secondary pneumothorax. Secondary is when another condition elsewhere leads to pneumothorax, such as injury, trauma, or another disease, okay? A tumor locally damaging pressuring the lung, the outside pressure, external pressure, because of the size of the tumor, may limit the expansion of the lung and make it be collapsed. Iatrogenic pneumothorax is when there is some surgical condition, okay, that would cause pneumothorax, like transthoracic needle aspiration. Okay, if it's not done correctly and there is this hole created, that can lead to the escape of air and then cause pneumothorax. All right, so here you would have sudden chest pain. Okay, pleural pain is reflected as chest pain. Tachypnea is faster breathing rate, and dyspnea. Okay, mild dyspnea, not so severe. Pain on inspiration. This is another way to diagnose this differential diagnosis. Sudden pleural pain is one important detail. A physical exam is where you may hear a tympanic percussion note. So it's a very specific sound that one can detect. And then absent breath sound on the affected side important. So breath sound is missing from the side that's going through this condition. All right. So lack of breath sound on the side of the lung that has pneumothorax. Severe hypoxemia, you would have expected that because of the limited gas exchange. And tracheal deviation away from the affected lung, because you're containing air in the thoracic cavity, there is that expansion of the thoracic cavity that deviates the trachea in the opposite direction. All right? Hypotension is another outcome of this. Okay, so these are the clinical manifestations of pneumothorax. Here, you're looking at open pneumothorax and tension pneumothorax. These are the other types of pneumothorax. Tension pneumothorax is an emergency situation. Open pneumothorax is where the pleura is not intact. That means air can move in to the pleural space. Air pressure in the pleural space equals barometric pressure, the atmospheric pressure, because air that's drawn into the pleural space during inspiration is forced back out during expiration. So this is the exchange of air between the pleural space and the atmospheric pressure. So that is air moving in and out, and the atmospheric pressure is what you find both outside and in the pleural space. Tension pneumothorax is where you're not able to release the air out. Air enters the pleural space. Let's take a look at it. Site of pleural rupture acts as a one-way valve. Okay, so the injury is in such a way that the area that's damaged now assumes the role of a valve. Air enters the pleural space, okay, permitting air enter on inspiration, but preventing its escape by closing up during expiration. So increased pleural cavity pressure. Okay. This is not the same as atmospheric pressure. It's over the atmospheric pressure. Increased pleural cavity pressure with each inspiration that causes compression atelectasis. That is, atelectasis is collapsing of the lungs. So the lung that's affected will now be collapsed because of the higher pressure, and it's a dangerous situation, okay, life-threatening situation. It needs immediate attention. Tension pneumothorax, all right? Open pneumothorax is where the air is in the pleural cavity, but it is not as with high pressure compared to the one in pneumothorax, all right? So tension pneumothorax is shown here. Outside air enters because of disruption to chest wall and parietal pleura. So now you see how the air is occupying this space and the lung is collapsed. Okay, lung air enters because of disruption of visceral pleura. All right, so air can escape from the lung. Air can enter the pleural space from outside injury. But whatever it is, it's not able to leave, and now that would increase pressure and make the lung collapse. All right, so that is tension pneumothorax. Let's talk about atelectasis here. As I mentioned, it is the loss of lung volume because of the inadequate expansion of the airspace. Okay, so it's the collapsing of the lung. Okay, there are many types here. First one is compression atelectasis. We just talked about compression atelectasis. This is external compression of the lung. That is what we saw with tension pneumothorax. Absorption atelectasis is where there is a slow release of air from the lung. Okay, airway obstruction by thick secretion prevents air from reaching the alveoli. All right, so there is obstruction in the airway. Air is not reaching the alveoli. Now, circulating blood in the pulmonary capillaries absorb the pre-existing air in the peripheral alveoli. Okay, so whatever air that was in the alveolus before this obstruction would gradually make its way into the pulmonary capillary and alveolar collapse. All right, absorption atelectasis is where you have to imagine a blockade in the airway. Now the alveoli with the air from before would slowly be entering the capillary, and therefore now less and less air within the lung. Okay, alveolar collapse is what you see. Most common cause are fever and dyspnea. Fever is not because of infection. Okay, it's fever itself, and dyspnea within first 24 hours to 36 hours after surgery. Okay, so you have a surgery, you have fever and dyspnea, absence of breath sounds, vocal vibratory sensation, and dullness to percussion are the ways to diagnose this. Okay, good. Atelectasis caused by collapse. This is spontaneous pneumothorax. We already talked about that. That is a decreased production or inactivation of surfactant. Spontaneously, we have pneumothorax, and that could be because of lack of surfactant. We talked about a number of other things like connective tissue disorder and so on. Here we are talking about the issue with the surfactant. What if there is not enough surfactant that causes collapse that you call as atelectasis because of the increased surface tension and causing spontaneous pneumothorax. Respiratory distress syndrome is again decreased surfactant. So these are related to the surfactant. Okay, the respiratory distress syndrome is how you refer to decreased surfactant within the lung, causing lung collapse. All right, and spontaneous pneumothorax. And now let's talk about pleural effusion. Okay, pleural effusion is the presence of fluid in the pleural space. This could also lead to collapsing of the lungs. Okay, transudative effusion, exudative effusion, and so many other different types. So let's talk about transudative effusion. So the content here is mostly water. It may be the fluid that comes out of the capillary into the pleural space. Exudative effusion is where you have debris, you have dead cells. Okay, less watery, contains high concentrations of white blood cells and plasma proteins. Okay, so it's more of solutes and cells than water, thicker deposits that you see with exudative effusion. So here you're talking about injury to the capillary. The content from the capillary is escaping It's not the diffusion of fluid alone, but it is the other content that is deposited here. Chylothorax is the lipid deposition within the exudate. Okay, so you have more lipid. We will soon talk about chylomicron, or let's talk about the lymph capillaries that you would talk about in the digestive system that carry mainly lipids, and you call them as lacteoles. So chylo reminds me of all those things, but here it is the deposition of lipid and lymphatic fluid that is in the exudate. Okay, hemothorax is blood in the pleural cavity. Any of these, again, could restrict the expansion of the affected lung, and the consequences are the same: decreased amount of air available for gas exchange, therefore less oxygen available in the body. All right. The same clinical manifestation: dyspnea and chest pain and pleural pain. All right, here we would stop the discussion of pneumothorax. There are many causes that we looked at. It could be the surfactant that's lacking. It could be the pleural effusion. It could be atelectasis due to many different reasons. All right, so tension pneumothorax is the most important or the most serious of all and needs immediate attention. All right, with this, we'll stop. Thank you.